Perfect. Fine. So would like to first of all thanks our own Dr. Bansi Sabu sir along with Dr. Vasant Kumar and Dr. Sanjay Agarwal for giving me this opportunity to speak upon the topic uh, diabetes self-management education. We would start with the quote that each patient carries his own doctor inside him and they come to us knowing that truth. We are at our best when we give the doctor who reside in each patient a chance to work. Education is the most powerful weapon which you can use to change the world. All the people with diabetes should participate in self-management education and receive the support needed to facilitate the knowledge, decision making and skill mastery necessary for diabetes self-care, and this was the quoted in ADA Standard of Care 2020. And also 2020 DSME's consensus report state that there are 4 critical times to provide and modify diabetes self-management education and support. Would like to divide my talk on 5 topics. We will first speak what is self-management education, how this concept arrives, which are the components we should focus, when we should provide and modify DSMES, and what are the recommendations for implementation. So self-management education is an intervention that involves active participation in self-monitoring and also decision making with the application of knowledge and skill. So physician will provide his knowledge and skill along with active participation and decision making with the patient. So both parties should be involved actively. What is the current situation? Diabetes epidemic is there. It's becoming expensive care. Targets are not met and diabetes self-management education is not utilized as per standard of care. We need to communicate the benefit of DSMES and engage the stakeholders, address barriers to the DSMES, and we must consider that it must be utilized. If we see only 5% of Medicare beneficiaries are with newly diagnosed type 2 diabetes are using diabetes self-management training, and that we need to work upon. We need to empower our patient because knowledge is power, and empowering the patient through self-management improves HbA1c, quality of life, weight loss, cardiovascular fitness, and many benefits are there. So which are these 7 core given by ADCES? It's a healthy eating, healthy coping, being active, monitoring, taking medicine, reducing risk, and problem solving approach. So we must focus on all these aspects of DSMES. Healthy eating without going in detail because we are having a separate session on diet today, but would just say that most adult only needs about 45 to 60 gram of carbohydrate in each meal. So this we need to promote and we need to educate our patient that proper timing, modest portion and well balanced meal should be there. Being active, always promote moving. So moving your body every day is most important. Walking, one of the best way to implement the physical activity. We must go at least around 10,000 steps a day. We must provide 150 minutes of physical activity every week. And if we cannot do anything, we just need to encourage the patient. कुछ नहीं तो थोड़ा तो शुरू करो. Even just 10 minutes a day is also being a great start. Even if you just avoid sitting less, that is also one of the benefit. So just encourage no sitting or sitting very less. That also being promoted and making the patient motivated regarding being active. Another part is monitoring, and that is where we are lagging behind. We need to focus on self-monitoring of blood glucose, HbA1c, blood pressure, cholesterol monitoring. As per the comprehensive diabetes care, the guideline given by ADA, we must encourage our patient to get themselves checked periodically to evaluate for the complication and save them from the devastating complication of the diabetes. Taking medication, we must encourage our patient, and it is right of our patient that they should know their medicine. So we must educate our patient regarding which sort of medicine they are having. So for making it simple, we are dividing medication into 5 classes. One is insulin provider. This is the drug where insulin and the drugs which produces insulin are included, like sulfonylurea and glinides. Another is incretin enhancer. This includes the medicine which help to increase the incretin hormone action, and these are DPP-4 inhibitor and GLP-1 receptor agonist. Glucose excreter. This is the drug which helps the glucose to excrete out into the urine. Insulin sensitizer, the drugs which improves the insulin action and reduces the insulin demand, like metformin and pioglitazone. And glucose restrictor. These are the drugs which stop glucose absorption into the intestine, like our A-carbo. So patient must know which medication they are taking, why they are taking, what is their basic pathophysiology for their type 2 diabetes or type 1 diabetes or any sort of hyperglycemia. If doctor has prescribed medication to help to control the glucose, we must educate the patient and encourage them to take the medicine regularly. And if either they miss the dose or forget the dose, we must advocate them how they should come out of it. And we must also encourage the patient how they can be associated with the loop of the network along with doctor, diabetes educator and patient. So diabetes educator can be an intermediator between the patient and doctor. Problem solving. So there are certainly going to be the times when patient will have tough time. If you see a patient with hyperglycemia, a patient with diabetes, they spend hardly few hours of the year with doctor. Rest of the time they have to manage their hyperglycemia by themselves. So we must empower the patient and we must encourage them, educate them how they can come out of it. If your sugar are going too high, we must have a look upon, we should talk to the patient, what they have eat, what type of carb they have eat, what was the portion of their meal, or they forgot the medicine, and we should try to resolve it. We should try to know the reason. So rather than being reactive, we must try to know why this is happening. Likewise, if a patient is having many lows, many hypos, then also we must go into detail why it has happened. Whether it was a long between the meals, or patient is not having enough carbohydrate, or patient is missing the dose, or patient is having too much of insulin. And we should figure out why the problem is caused, and we should figure out and we should try to solve this problem. Reducing the risk. Our patient must know what type of risk they are having during their diabetes tenure. Why I say tenure? Because they are going to live with for the prolonged period of time. So having diabetes again puts their each and every organ at some sort of risk. So we must encourage the patient to visit the doctor on regular basis. If nothing, then at least once a year to get the sugar control. And if it is out of control, frequent visits should be encouraged. It is recommended at least dentist visit every 6 months, at least once a year, ophthalmologist visit. Smoking and diabetes, a bad combo. So if a patient is smoking, we must talk to the patient, and as a doctor, we should help them to quit it. And finally, we must educate the patient to look at their feet and take care of their feet. So, of course, this sort of the things regarding reducing the further risk in the life, we should educate to the patient. And lastly, healthy coping. And this is the era of stress. Each and every part, each and every component, each and every community, each and every age is having some sort of stress. And dealing with diabetes is creating more stress. We call this diabetes distress. And this stress, if it is persistent, it's going to raise the blood sugar, and we must help the patient to come out of this diabetes distress. So there are a lot of ways a patient can come out of is that. Best stress relievers can be just improving daily physical activity, meditation, and encourage the patient to live their life. Encourage the patient to develop a hobby, or whatever hobby they are having, to go into that and just enjoy the life. And that is what we need to require. At least at any cost, quality of life must be good. So it's important to seek the support of friends, family, or even some diabetes support group to improve diabetes distress. And for a physician, the blue index is coined so that this can be act as one of the tool for diabetes self-management education. They must know that score, and patient will be then proactively asking how they can improve their score. Something which you can measure, then you can improve. Based on that, it was coined, that is known as diabetes health score or the blue index. How it can be delivered? It can be either interprofessional team, likewise a team of a doctor with dietitian, diabetes educator, or diabetes specialty nurse. Anybody can involve. Personal contact with healthcare worker. So any healthcare worker can be promoted, can be educated. Combination of group and individual session. Likewise, monthly you call all the diabetic patient and have a session regarding what the problem they are facing and coming out of the solution. Many times one patient will find their solution from other patient. What are the problem they are having, how they are coming out of their problem, and that may be the solution for other patient. So this combination is must, is required, or you can put some didactic or interactive combination. So there are many ways we can deliver self-management education. One another entity is self-management support. It is a strategy which augment individuals' ability to self-manage their diabetes. And this include frequent follow-up of a healthcare provider, diabetes coaching, peer group support, community health worker, and linkage between the support group and interest group. And this combination of SME and SMS is the most advantageous for improving glycemic control. So assess, identify the personal self-care need, make an informed consideration of self-care option, collaborate on the decision, goal of the action along with the patient, implement a realistic plan, and evaluate and support the long-term self-management. So engage the patient, assess, plan it, implement it, monitor it, and if required, re-evaluate it. And again, so it's a collaborative, interactive, and individualized approach to get their healthcare target. 4 critical times when we must provide, we must encourage and modify this diabetes self-management education. First is at the diagnosis. Second, annually or when the targets are not met. Third, when complication or factors are developed or transition of life. So majorly nutrition, emotional health, along with education, and at each and every point we must assess the patient, their condition, and we must re-evaluate the whole plan of diabetes self-management education. So at each and every point we must go into the detail of these 7 parameters and then educate accordingly. Many benefits are there. We can provide critical education and support for implementing treatment plan. It reduces the emergency visit, it reduces hypoglycemia, reduces all-cause mortality, lowers the HbA1c. Sorry. And suppose if it is given as a pill, should we prescribe? There are the evidence where diabetes self-management education and metformin. If you see, benefit are as equal as metformin. So even before metformin, we must advocate and we must encourage, we must emphasize on the diabetes self-management education. Sorry, can I have water? So if it is coming as a pill, we must prescribe it. So before a pill or along with pill, we should give diabetes self-management education. When we should refer the patient for diabetes self-management education? All newly diagnosed, as I have discussed, annually or when targets are not met, or when any complication develops, or when transition occurs, like changing in living situation or new clinical care team. And there are the evidence, it involves both the group and individual education provided by a team or single individual. Participants should attend all the, and it is recommended to involve healthcare policymaker, payers, system provider, care teams to implement this diabetes self-management education. So to summarize, there is a lot of evidence that DSMEs is important. It is grossly underutilized. The concession report says that there are 4 critical times we can provide and modify the DSMEs, and we must give the clear guidance when to refer to this diabetes self-management education services, and we must give the checklist to the patient, and health system and provider should mobilize to ensure that all people with type 2 diabetes should have easy access to the diabetes self-management education services, including nutritional, physical activity, and emotional health support. Considering automatic referral to DSMT and MNT, opt-out, various opt-in. So we must advocate this, and this was the end of my talk. Thank you.